Okay, good morning, everyone, and welcome to this webinar. Thank you all for attending. You are uh, being presented this morning to the the Maryland Regional Disability Direct Services Collaborative, and we're an organization that's been around for almost 3 years now. So, trying to really improve the workforce for people who need direct care. In my situation, that involves people with significant disabilities, um, many of them who live in the community and receive direct care. We also work in nursing homes to help people get out and get back into the community. But one of the ongoing concerns is the issue of quality of care and availability of care. You'll hear this morning from our panelists about the wages, the issues of wages, and the issues of quality care and the future and how we get there. I want to thank, before we go on, the Rodham Institute at George Washington University for the School of Medicine and Health Sciences. They have really been a partner with us since the very first meeting, since the very first day. The Rodham Institute has shown that they care about these issues and want to advance them for the Maryland and DC region, and we can't thank them enough for that. This morning, we're going to talk about the effect of COVID-19 on transforming the frontline direct services workforce. What's happening, what needs to happen, and the approach that we need to take. It is clear that we need to take a we approach, that it is a collaborative effort that needs to happen throughout the region and throughout the country, because each of us is one disability away from needing that care. Whether that disability comes because of age or because of accident or because of illness or being born with it, all of us will at some point have a family member or we ourselves will need that direct care, and that direct care will only be available if we create the availability now. We are clearly in a situation where the workforce currently is unprepared. I won't go into all the details, but we have some folks on the panel this morning who will be talking about it. What we see at the Image Center is an often chaotic and very dangerous environment for folks with significant disabilities who are in need of direct care. But really, to give us an overview, to take a look at what's going on generally, and to sort of set the tone for this morning's presentation, I want to introduce Robyn Stone. Robyn has been with us since the beginning of this endeavor. She's the Senior Vice President for Research at Leading Age and coordinator for the Leading Age Long-Term Services and Support Center in Boston, Massachusetts. She has seen this field for 40 years and so brings a multi-generational perspective to the challenge that we face. COVID-19 transforming the direct service workforce in 2020 and beyond. I present to you Robyn Stone. Robyn?
Thank you. Thank you very much, Mike. And if we can get the slides on the screen. Perfect. Thank you, and thank the collaborative. It's been a wonderful experience to, since I live in this region, I actually live in DC. I was born in Baltimore, and I have a very strong commitment to this region in general, and we need to work on this. We had some serious challenges before COVID. COVID shed some more light on the challenges, and hopefully we can take advantage of what we're learning from COVID moving forward. So, I wanted to just start by talking about what this sector is. Oh, if we could go back, yes, please. We really are talking about everything from a post-acute skilled nursing facility, home health care, the sort of the post-acute services that people get after they leave a hospital, to residential services in nursing homes, assisted living, memory care units, small group homes, the whole range of residential services that are available to people across the disability spectrum. home and community-based services that include home care, personal care, and also instrumental activities of daily living assistance, supportive services that may include meals and transportation, independent living, both in market rate and also subsidized properties, and care service coordination across settings and with acute and primary care. And I wanted to define that because I think it's important for us to understand where these direct service workers, or I call them direct service professionals, work. They are throughout the sector. Obviously, they are also in the hospital sector, but most of our work is really focused on the residential and community-based sector. But all of these settings have millions of care professionals in them every single day. And so, don't just think about one part of this. It's not just the nursing home. It's not just the small group home. It's not just people's own homes. It's across all of these settings that we need a quality workforce. And if we go to the next slide, I want to talk a little bit about why this direct care professional occupation is so important. First of all, when we think about where, if we can go back, if we think about where people are getting their services and supports, this is an intersection between the medical care system, the social care system, and the physical environment, the environment that people live in. This is a very, very complex world that this workforce works in. And this frontline professional provides 60 to 80% of all the hands-on care that is delivered in this country, after family members who do the majority of unpaid assistance. This frontline workforce, your nursing assistants, your home health, home care aides, your personal care attendants, your direct service workers, your dietary aides, these are the folks who actually do the lion's share of the work. So it's sort of a no-brainer that if we're not investing in this workforce, we're not investing in our sector to improve quality for everybody. This is also a mostly female, low income, many people of color, and a large immigrant population. Between a quarter and a third of this workforce are immigrants. So we need to be understanding that we have a fairly disadvantaged workforce doing a lot of the work and heavy lifting in our organizations, and whether it's in one's own home or in a residential environment. So understanding the dynamic of this frontline workforce is really important, I think, as we move forward. So let's move to the next slide. So the long-term trends, not the COVID or today's trends, but the long-term trends is that we're going to see an emerging care gap even before COVID. We had problems with the pipeline. We have issues around family caregiving that we may actually see increasing over the next 20 to 30 years as the population ages. We're seeing a shift from institutional to in-home and community-based settings. So we need more workers who are employed in home-based and community-based settings. We're seeing more ethnically and racially diverse older adults as well as staff. So the cultural competency and the issues around systemic racism are really, really critical. And we see more highly educated, on the whole, more highly educated, demanding older adults and clients in general, which is going to put a lot more pressure on this workforce. We go to the next slide. We also see, and COVID is shining a big light on this, greater disparity between the haves and the have-nots. And it is interesting that we have a lot of this workforce who are the have-nots, who are caring for the most vulnerable in our population. We also see an expansion of consumer-directed service systems, more and more responsibility falling on the individual consumer and their family to hire, place, and support this workforce. And then the uncertainty around this is, what is the impact of new technologies? I will tell you that my crystal ball tells me that we are not going to be having robots replacing this workforce anytime in the near future. So this is a very, very labor-intensive sector. And if we move to the next slide, why is this sector so important? Why is this workforce key to us? Well, if we never even cared about the workers themselves, the growth of the elderly population alone, just the aging of the population, as well as the aging of younger people with disabilities, and younger people with disabilities living much longer than they did in the past, makes this one of the fastest growing occupations in many localities across the country. Secondly, we have a lot new models of care that is creating new types of jobs in this sector, more opportunities potentially for this workforce. This workforce is an economic driver in many communities, including rural and other worker shortage areas. And finally, I would say that if we want quality, we must have a quality workforce. There's no magic bullet that somehow we're going to get a fantastic financing and delivery system without the investment in the workforce that does all the work. So let's move to the next slide. So what are our challenges? And I'm going to go through these pretty quickly. We've got significant recruitment challenges. We have pipeline challenges. We have retention challenges. This sector is rife with serious turnover in the nursing home, in residential care, as well as in the community. And we have a lack of competent quality staff. So many times when we have challenges like we're having right now with COVID, everybody is looking for a warm body. And what I would say is we should not be and will not be looking for warm bodies. We need a competent quality staff to support the work that is going on in all parts of our sector. And finally, COVID is unique in many ways, but it has exacerbated and shined a light on this workforce finally as essential workers. And by the way, our frontline staff were not even considered essential workers in the very beginning of this discussion of this pandemic. The hospital sector was receiving all of the attention, and it was mostly nurses and doctors. But as people started to see the challenges in COVID, and let's go to the next slide and we can talk a little bit about that. This is just some data from COVID death and case data from Maryland and DC. DC nursing home data from DC Health mid-March, just mid-March to October 16th. Resident cases 722, staff cases 405, resident deaths 163, and staff deaths 7. And of course, that's just what was reported. In Maryland, across the nursing home, assisted living, and group home sector, resident cases were over 3,500, staff cases were over 2,500, and resident deaths were 774. Staff deaths reported was 9. And then the Maryland overall deaths and cases since the beginning of this pandemic is total cases were 16,000. That includes residents and staff. And total deaths were over 2,000 people of residents and staff in Maryland have died from COVID. And this is a travesty for all of us. But if we go to the next slide, it really is a travesty for this frontline workforce. And that's why I would like to say that COVID is important, but COVID at some point will go away. We will remain having these significant challenges with our workforce, which has been undervalued for years. As long as I've been working in this sector, this is an undervalued sector. Ageism is part of the problem. It leads to a lack of attention and investment. And I should also include stigma around disability. While we have improved substantially post-ADA and Olmstead and all of those things, we still have a lot of challenges around getting people to value the jobs that these folks do. These jobs are seen as easy, default, and places where people go after they're burned out from something else. It's not unusual for me to talk to a policymaker who still considers direct care professionals as butlers and maids. And as long as we have a societal level view of that, it's very, very difficult to change. We go to the next slide. Reasons for the challenge at the policy level. We have had substantially inadequate public reimbursement, particularly through the Medicaid program, which covers a lot of our services and therefore is responsible for, quite honestly, the money that goes toward wages and compensation. We have a lack of universal financing for long-term services and support. So what happens to the family that isn't qualifying for Medicaid? your modest and middle income people who can't afford to purchase care either in the nursing home or in a residential environment or at home. We have very uneven regulation, particularly in the nursing home setting, which focuses mostly just on numbers of staff and ratios of staff and doesn't pay much attention at all to the quality of the work environment or actually how staff are prepared and supported. We have a serious lack of standardized competency-based training requirements and programs across the country, and that is true in Maryland and DC as well. We have a lack of workforce development to professionalize these occupations. We have a lack of opportunities for career advancement, and career advancement may mean a career lattice where you're actually moving into a specialty position, like caring for people with dementia or caring for people with mental health issues, or becoming an oral health specialist, which is one of the growing jobs in this area. There's a lot of opportunities for lattices as well as career ladders. And if we continue to think that all aides just want to become a nurse, we are missing the tremendous opportunity for the development of this workforce in areas like social work, management. These folks are fantastic people managers. They ought to be moving into very, very different, diverse career paths, and we have sort of put them in a little hole where there's not much room for exploration and creativity. And then we have uncertainties around immigration policy in this country. And trust me, the more we close our borders, the more it is going to be difficult for us to find a pipeline in the future. So let's go to the next slide. At the workplace, we also have challenges. The biggest reason why people leave their jobs, and we have done work in this, as have done many other folks, is the lack of quality supervisors. So our investment in supervision, whether it's in a residential setting or increasingly in home care, where often our aides don't even know who their supervisor is. That's how bad it is in this sector. We have inadequate onboarding and in-service training. Again, a lack of career mobility, which is really a responsibility of employers as well as policy folks. Certainly inadequate compensation and benefits. And while I can talk about the challenges of Medicaid reimbursement, it is also the responsibility of employers to look at their budgets and recognize that they need to be competitive in the marketplace. People can leave and make more money in fast food and other hospitality jobs, which are not nearly as complex and challenging as these jobs are. And finally, this sector, for the most part, is not competitive technologically. If we want to recruit millennials, we better start paying attention to that. So let's quickly, very quickly go to the next slide and some of the solutions. So what do we need to do? In the short term, there have to be COVID-related interventions. We must have appropriate personal protection equipment, testing and contact tracing. Because a lot of this infection is brought by the frontline workforce who goes in and out of buildings and people's homes, it is essential that they are protected and that we understand that this is a neighborhood community problem and not just the LTSS setting problem. Then we have to think about the more long-term consequences of all of this. Medicaid and Medicare reimbursement has to be tied directly to workforce development in terms of both the reimbursement and thinking about training, standards and modules and programs that are available and are affordable. Targeting GME dollars. I have often thought that graduate medical education monies and other federal and state dollars, we need to look at other dollars for where we might bring some of these money. Medicare supports those GME dollars, those graduate medical education dollars. We need some of that in our sector. We need support to support investment in these jobs in worker shortage and disadvantaged communities in inner cities as well as in rural communities. We have to think about immigration policy in a much more targeted way, including the use of refugees, which we have had some fantastic examples of that around the country. Incorporate competency requirements into new models of care. If value-based payment is moving everybody out into the community, what are the competencies that are required to make that happen? And we have to think about things like nurse delegation. with this workforce, with these careers, frontline aides can have a lot more opportunity if they are allowed and are empowered to do the work at the highest level of what they can do. And oftentimes nurses get in the way of this. And this has been a serious challenge certainly in DC, but in Maryland as well. Let's move to the next slide. Education. We have to have faculty and curricula to train this workforce. We have to invest in it. We have to have good placements for this workforce and for the supervisors who are going to be working with this workforce. We have to expand career ladders through apprenticeship programs that are strong and multi-year and significantly invested in on both the policy side as well as the employer side. And I also think we need to reframe some of these programs for displaced and older workers who have great potential in the pipeline for solving some of our workforce shortages issues. So finally, let's move to workplace solutions. I believe every employer should become an employer of choice. We have to develop innovative career ladders and lattices within our organization, support quality management and supervision. I tell Leading Age members this all the time. If there's one thing that you could do as an employer, invest in your supervisors. They need to be coaches. They need to be educators. They need to be people who are actually working with the frontline professionals to create a healthy workplace and to produce quality outcomes. We have to have much more robust orientation and in-service. We love peer mentoring programs because they have actually had very strong empirical effects. Every organization ought to be developing peer mentoring. And then finally, we have to think thoughtfully about how we use technology to support and complement human capital. It's not going to replace our human capital, but there is a lot more work that we can do with technology with the front line, including have them using their own PDAs, their own phones, to actually document and share information and become part of care teams. Right now, we make them leave their phones at the door. They ought to be using them. For younger people, this is part of their body. And they ought to be using them, and we should be using the technology to support this workforce and to allow them to grow. I think with the time that we have left, I'm going to go very, very quickly through the rest of these slides. I want you all to know, rather than going through this, that Leading Age has just released a new report called Making Care Work, Making Care Work Pay. And you can access this report on our website, which is www.leadingage.org. It really talks about the benefits of a living wage for every single frontline worker. And all I can say is, in summary, that if we paid every worker a living wage, we would see growth in productivity. We would see stronger economies because money will be put back into the local economies, particularly where these folks live. We'll see people getting off of public assistance who are currently on public assistance. We will see a growth in the individuals in the pipeline who are interested in filling these jobs. We will actually attract frontline caregivers from other parts of the lower wage sector, and everybody wins. And finally and foremost, the frontline aides will have a lot more economic security and opportunities for growth. And we think a living wage is part of the building blocks for creating and professionalizing this workforce. And I think with that, I'm going to close. I have a few more slides, but I want to leave us plenty of time for the panel discussion. I am extremely hopeful. I think COVID will not necessarily transform our sector, but I think COVID has shined a light on the essential worker, the essential professional. And we need to take advantage of the momentum that we have from COVID to build this workforce so that we have the availability of quality staff for the people who need it. And we are also developing professions for a large group of individuals, primarily female, living in our communities in Maryland and DC today. So thank you very much. And Mike, I'm going to turn it back over to you.
There we go. All right. Well, Robyn, that was a profound summary and really excellent. I want to thank you, and I'm sure we'll put it up soon. But these broadcasts are available later on the George Washington University website. So we'll get information out to all of you who are here, and you can circulate it to your friends. I'm going to use this with my staff. That was phenomenal, Robyn. Thank you. But really, now to delve more in depth into the situation and the crisis that we are in many ways, I want to turn it over to our panel of really involved experts and professionals in this field. Mike DiGiacomo is going to take charge of this panel. Mike DiGiacomo is the executive director of the Governor's Governor's Workforce Development Board. Mike has been involved with us since the very beginning, has a profound knowledge about labor and labor force activities, and he will introduce and moderate this next panel. Mike?
Thank you, Mike. What I'd like to do is to begin by introducing our panelists who have each prepared 10 minutes of remarks. Our first panelist is going to be David Rodwin, who's an attorney with the Public Justice Center, followed by Wendy Wells, who's the program director for workforce development and continuing ed and nursing at Montgomery College, and conclude with Sharon Krause, who is the president of the Maryland Association of Community Services. And I'd remind everybody, if you have questions, to put them into the chat, and we'd like to make this an interactive session. So with that, I'd like to formally introduce our first panelist, David Rodwin, an attorney with the Public Justice System, who serves as an attorney for the Workplace Justice Project, is currently the vice chair of the collaborative, and chairs the collaborative's Wages and Benefits Task Force. With that, I'll turn it over to you, David.
Thanks very much, Mike. And thanks also to Mike Bullis and to Robyn for a really outstanding presentation and a great summary of where things are right now. So, Christina, if you could please advance the slide. The topic of today's presentation is transforming the direct services workforce. And the perspective that I'd like to try to share is that of Maryland's home care workers. So here at the Public Justice Center, where I work in our Workplace Justice Project, a good chunk of my work is representing home care workers who've had some of their labor rights violated. And so I sort of get the perspective from them, from a sort of ground level perspective of what's important to them, what's happening with them, with their work, and how it's affecting their lives. Over the past, how many months has it been? I keep in my head, I say 6 months, but I guess now it's been closer to 9 months that the pandemic has really been happening. We've seen how the pandemic has affected workers, their lives, and their work. And so that's what I'm going to try to talk about today. So Christina, if you could please advance. So let's begin with just a brief sort of summary of what was happening before the pandemic with Maryland's home care workers. And just so that we're all on the same page, and I think that probably everyone on this webinar already knows this, but when we say home care workers, we're talking about like personal care aides who are going into people's homes and providing assistance with activities of daily living and or instrumental activities of daily living, which really just means help that allows someone to stay in their home and community and be sort of independent in their community and not have to go to a nursing facility. So a lot of that work looks like, it can be sort of lifting, help with sort of hygiene, cooking, cleaning, and other sort of things that allow someone to remain independent. So what was it looking like beforehand? Well, the job quality was very poor and there was very high turnover. Most of the workforce in Maryland and across the country is funded by Medicaid, which means that the people who receive care are Medicaid recipients. And that means that the money that funds that work is a mix of state and federal money. It's mostly federal, but it's a very good chunk of Maryland's budget as well. And unfortunately, that means that there's an incentive for the state to reduce Medicaid costs, which here are home care worker wages. And the way that plays out is that here in Maryland right now anyway, there's only one service delivery model for Medicaid funded home care, and that's through home care agencies that are called residential service agencies. And the state's reimbursement rate, in other words, what the state pays a residential service agency to perform an hour of home care is about $18 an hour. I think it's increased a little bit just a couple months ago to 18 something. And from that 18 something an hour, the residential service agency, the home care agency, pays the worker and pays any overhead costs or associated costs with running the agency. What that means is that workers get very low pay. On average in Maryland, it's 12 something dollars an hour, and that's an average. So many workers are getting below that. And that 12 something an hour also includes workers that are not funded by Medicaid. So private pay workers that generally speaking get more, $15, $16, $17 an hour sometimes. And so what that really means is that a lot of workers are getting $11 an hour, $11.50 an hour. And unfortunately, because the reimbursement rate is so low and because there is very little labor oversight, you have a whole bunch of the home care agencies that receive Medicaid funds misclassifying their workers as independent contractors to avoid paying employment-related tax withholdings, FICA, FUTA, unemployment, workers' comp, and other associated costs that you incur when you classify your worker as an employee. And as I see Dawn has pointed out in the chat, that difference between the $18 and whatever they pay the worker in wage is supposed to include those various payroll taxes and also the nursing services that go into being a residential service agency that Medicaid doesn't reimburse. All of this is sort of a result of this, what we sometimes call in law and economics a perverse incentive for the state to reduce its Medicaid costs, and that leaves agencies with not a whole lot of money to play with. And so as a result of that, and a lot of agencies do the right thing and classify their workers as employees when they are employees, but many don't. And there's 470, I think, ish, give or take a few, home care agencies that receive government money here in Maryland. And many of them, in my experience, are misclassifying their workers as independent contractors. And that cuts those workers out of the social safety net entirely. They don't get workers' comp when they're injured if they're independent contractors. And even if they are actually employees, they have to go through a whole process that'll take months for them to prove that they're employees if the starting process is that they've been classified as an independent contractor. They don't get unemployment insurance if they lose their job, sick leave under Maryland law, overtime pay, even protection from workplace discrimination. These are all things that employees have that independent contractors don't. So this was the sort of lay of the land before the pandemic hit. So Christina, if we could please advance. Now, what about during the pandemic? So it's even worse. We have even worse job quality and even higher turnover. So workers have been calling out because either they're scared or they have additional childcare responsibilities because there's no school or camp or whatever. So there's much higher turnover. And the job quality is even worse because now workers are incurring additional expenses for PPE and hand sanitizer and other things. And they're risking their lives to leave their homes, to work outside of their homes, often traveling by public transit to get to multiple people's homes in the same day where they're providing that care. And the wages haven't changed. They haven't gotten hazard pay like some other industries have. Maryland, unfortunately, did not apply like some other jurisdictions, like DC did, to have a portion of the CARES Act money be used for hazard pay for personal care aides. Lots of other jurisdictions did it. Maryland did not. That was a choice. There have not been, so Governor Hogan did some good things with respect to executive orders that provided essential workers with certain benefits. For example, state-funded childcare during that chunk of time when the pandemic first hit and everyone was scrambling. Unfortunately, we did some reading about, I think everyone saw in the news, the PPP loans mostly went to businesses that already had strong relationships with their banks, already were more resourced. The same thing happened here, where already the better resourced, higher income people who are more sort of savvy and able to learn about what benefits are available to them took advantage of that and were able to get free childcare. Home care workers didn't even know that they were classified as essential. And none of the many workers I spoke with knew about their entitlement to free childcare and therefore didn't take advantage of it, which led to the higher turnover. So there hasn't been communication of their benefits to them. They've received no formal pandemic training, except whatever a home care agency might have decided on its own to provide. None was required. There has been very little agency provided PPE in my experience, and no government provided PPE to these workers. Some agencies, there are always agencies that do the right thing and decide to provide PPE, that even when it's been hard to procure, and it certainly has been hard to procure. Definitely want to acknowledge that, but there's been no requirement that they provide it. And the misclassification of these workers as independent contractors is making everything worse and more dangerous, because when you are classifying your workforce as independent contractors, you're less likely to provide them with training, with PPE, with other sort of pandemic related protections that protect workers' lives, consumers' lives, because these workers are traveling to multiple people's homes, and the lives of workers and consumers' family members. So the fact that many home care workers are wrongly called independent contractors is really, it can have, and I don't mean to be alarmist, but the consequences can be deadly. So if we could please go to the next slide. So that was all a bunch of bad news. How can we make things better? Well, whenever something is really bad, it also means that there's a great opportunity to improve, and there are opportunities to make things better here. And the easiest way and best way, as Robyn was saying, is to improve job quality. One low-hanging fruit is to extend the existing social safety net to workers by making sure that workers are properly classified as employees when they're employees. Existing benefits to workers' comp, to health and safety, to various labor protections, all exist already for employees, but workers lose that when they're wrongly called independent contractors. So stopping that misclassification is a low-hanging fruit that can have great benefits during the pandemic, especially that can be health and safety benefits. Pandemic protections. So let's make sure that this frontline workforce is empowered with information that they can use to protect themselves and those that they're interacting with some very basic pandemic related training and with PPE. These trainings exist. Some of them are free online. We sort of petitioned the state to try to get them to require providing it, and they could have it reimbursed through Medicaid to ensure that people do it. Unfortunately, that hasn't happened yet. But you really want to have your frontline workforce empowered with information so that they don't spread this disease and not just rely on them independently learning how to protect themselves and others. And third, let's increase pay for these workers. Let's make sure that they're not living in poverty and that their families are living in a constant state of crisis. We can do that through an increase in the Medicaid reimbursement rate with what's called a wage pass-through to workers. So you increase the rate, and then you also at the same time require that some percentage or dollar amount of that increase goes to workers, so that you don't have a situation where just the agency gets paid more, but it doesn't trickle down to the worker. And some agencies will pass it along and others will not. And we can't just rely on the good actors doing the right thing. We have to require that all the actors act in a way that benefits workers, consumers, communities, and Maryland overall. So in short, I would say things are very bad right now, just to be blunt, but there are opportunities to fix it. They just require us to take some action and just to look at the problems, without rose-colored glasses and just to address them head on. So I'll leave it there.
David, thank you very much for those really informative remarks. I'd now like to introduce Wendy Wells, who's the Program Director for Workforce Development and Continuing Education and Nursing at Montgomery College. She has served as the chair of the Affinity Group for Healthcare Professionals under the direction of the Maryland Community College Association for Continuing Education and Training. She's worked collaboratively to focus on the needs of Maryland's multidisciplinary healthcare workforce with the advisory group representing each of the 16 Maryland community colleges. And she provides leadership and training support for the CNA program developed by Dr. William Leahy and the Family Foundation. Wendy, the floor is yours.
Thank you, Mike. Today I will be discussing what the community colleges had to go through in order to teach the CNA GNA programs virtually. We're going to talk about how are we working with COVID-19 now and my thoughts about the future. Can we advance the slide, please? March 18, 2020, COVID-19 hit. All the colleges were being notified that they're shutting down. That was an immediate impact on the community colleges. All the community colleges had to scramble to figure out what they were going to do to continue training the remainder of students that were still in class. It was a totally focused chaos. This was the most stressful time in my career as a manager, an educator, and as a nurse. Colleges were given about a week to come up with a plan on how to transform our face-to-face classrooms to virtual classrooms. We had to train our faculty on Zoom and our Blackboard before we went into full remote. The CNA GNA faculty had a disadvantage because many of our faculty have not taught remotely. So the question was, how are we going to teach these students that are still taking our CNA GNA classes? Advance the slide, please. The first thing we had to do was to obtain permission from the Maryland Board of Nursing. Because why do all of this planning if it's in vain? We were having an AG-HEP meeting, which is the advisory group that represents all the 16 Maryland public community colleges, workforce development training units. We were having a meeting at that time, so we called Karen Evans, the executive director of the Maryland Board of Nursing, to this meeting. She was able to give us permission on the spot to use technology and simulation for our CNA GNA programs, and in addition to the nursing programs for the state of Maryland. And although we're not talking about medical assistance, that regulatory agency denied e-learning for those students. So that left hundreds of students unable to complete their programs because they wanted to wait for face-to-face programs. Subsequently, Governor Hogan issued an executive order which backed up Karen Evans' use of technology and simulation to train our CNAs and our GNAs virtually. And then the other regulatory agency, again, was Pearson VUE, which is the geriatric nursing assistant exam. That was halted as well. Can you advance the slide? We had technology challenges because, again, the question was, how are we going to transfer face-to-face learning to e-learning in a very short period of time? For most of the community colleges, the CNA faculty have only taught face-to-face. A lot of our CNA GNA faculty are retired nurses. So a meeting was scheduled with AG-HEP, which is the group that represents all of the community colleges. And we invited the CNA GNA instructors from the 16 community colleges to share ideas on how to conduct classroom, teach nursing skills, and clinical virtually. I mean, I have a strong simulation background, so I had to convince not only my staff, but this group that we could teach our students virtually. Some colleges at first waited to see if the pandemic would go away and did not continue with teaching their CNA GNA courses virtually. So those students were kind of left hanging. Community colleges had to develop training, which we call structured remote training on Zoom and Blackboard. Because if you're used to training face-to-face, you know, it's a little different when you're training virtually. So classes have to be developed to train WDCE faculty. Once faculty was trained, and they were able to orient the students on the technology. And then the other problem that we had is that not all students had computers, but there was a study that came out shortly after we started training that a lot of students were taking their classes via their cell phones. And then those students without computers, we had to refund their money. Emergency funds for computers, so some of the colleges were issued. But then again, our training programs are shorter. You know, it takes about up to 3, depending on the program that you choose, it can take up to 3 months to train a CNA, GNA. But by the time the paperwork was issued, the class was over. And then it was such a high demand for computers, we ran out of computers. The same week, colleges started to receive letters and phone calls from nursing homes and hospitals that they could no longer take students in the healthcare facility until 2021. There's another issue that we have to resolve and still are in the process of trying to resolve. Very stressful for those students who were still finishing the term in their clinical sections. Today, when hopefully when nursing homes and hospitals allow students again, back into the facilities again, they're going to be requiring COVID-19 testing weekly, and the schools must provide PPE. And I heard one of the other speakers talk about PPE, and the college is going to incur that cost. And eventually that cost is going to have to be, at some point, we're going to have to pass that cost on to the students via the tuition. And then with the N95 masks, that's even another story, because they have to be fit tested for those in order to go into the facilities. The facilities are not fit testing our students. So right now, some of the colleges are looking into using the fire stations to fit test our students for masks so that they can go into the healthcare facility. Some of the changes occurring with nursing homes are that they will not hire students without that GNA certification. The CNA certification only allows employment for up to about six months in a nursing home, and that's with begging the Maryland Board of Nursing for extensions. And again, this allows them employment again for 6 months. This allows the time to schedule GNA testing at a regional center. And really, I think there's only about 3 regional centers in the state of Maryland, and they just opened up for GNA testing, I think in June or July, and there is a wait list. The Maryland Board of Nursing has made it clear that CNA should not be working without a GNA certification in the facilities. As you may or may not know, many of the GNA test sites are at our community colleges, where the state comes in and tests our own students. Now they have to go to the regional testing centers, which poses a problem, again, of wait times. And in that wait time, students may forget skills, and this puts them at risk of not passing the GNA certification. On the other end of the spectrum, some hospitals are hiring CNAs. Hospitals do not require GNA certification. Personally, I have been contacted by a couple of home health agencies who are willing to pay CNAs $35 an hour to take care of COVID-19 patients at home. Now, the challenges of working with COVID-19. Some community colleges are partially opening, meaning that students, CNA, GNA students are able to come in and do their labs. And also this requires students take temperatures or do the COVID training and answer questions before entering the buildings. There's a limited amount of students per classroom. There's a limited amount of students per lab. The normal ratio is 1 instructor to 8 students. Now the new ratio is 1 instructor to 4 students, depending on your space. And in the healthcare facility, most facilities are not accepting students to practice their CNA, GNA skills on patients. And they're limiting the amount of clinical students in the facilities as well. The normal ratio is 1 instructor to 8 students. Now the new ratio is 1 instructor to 4 students. This creates problems, a cost of hiring more instructors. And then the new thinking is that, you rotate through the students through which is differently, group A, group B, which means the colleges are saying that they don't want the students exposed but a short period of time. And if there's a positive COVID test, they want to make sure that the contact tracing is specific. So we want to keep our groups together. So again, that cuts down on the clinical practice that our CNA students may have. And again, we've talked about requiring students and faculty to test weekly, and the college is having to incur the testing and the PPE. And then there's testing, of course, testing for positive procedures as well. So the next slide. So what does the future hold? I don't know, but from where I sit, this is what I see. Fiscal year 2021 budget cuts. Some schools have already furloughed CNA faculty, but hopefully administration does understand that nursing homes and hospitals do need certified healthcare workers. Hopefully healthcare training programs will not be cut, but that is a reality. Second wave of infections possible. I just heard on the news yesterday, this isn't the second wave, there may be a third wave, but I just heard in the news, if this happens, the virtual training will have to be, the virtual training that we have already put in place will not be affected. It's working. So, because the workforce has to be replenished. This is a good thing. Vaccines, that's what we're all waiting for, right? How long is it going to take? This will affect continued training and educational changes because really face-to-face education is the best, but we're working with what we have. Home health agencies are desperate to hire CNA to take care of COVID-19 patients at home and are willing to pay. Will this be the catalyst for increasing hourly pay for direct services workers? I don't know. Executive order, Maryland Board of Nursing, Maryland Higher Education Commission. These regulatory agencies determine how long e-learning continues. MHEC in particular has noted that the pandemic has lasted longer than anticipated. I learned that MHEC is working with the Maryland Board of Nursing to come up with guidelines for CNA e-learning. This may become problematic in delaying the program renewal process for our CNA programs. On the other hand, all CNA e-learning programs will be more consistent. So, but we're not sure of what new expectations will be required. Reluctance of high-risk instructors to teach face-to-face clinicals. Many of our CNA instructors are retired. Many have expressed the fear of going back into the nursing home to teach clinicals. So this is an issue. So in conclusion, COVID-19 has changed the way training is delivered. But I think this is a positive change. We needed to accelerate the use of technology to enhance teaching and learning modalities. This is no longer the wave of the future, it's here. And I think the longer the pandemic is around, the better we'll get as time moves forward.
Wendy, thank you so much for those insightful remarks about the impact of COVID on the education system. Now I'd like to introduce Sean Croce, who's the CEO of the ARC Northern Chesapeake region. Sean has worked at the ARC North Chesapeake region since 2002 in several leadership positions. Her leadership has brought about a realignment of staff to empower people with differing abilities to work and thrive in the community. She also serves as the president of the Maryland Association of Community Services. The floor is now yours.
Thank you, Mike. Thanks for having me here this morning. First, I want to share with you who we are and how we were specifically impacted by COVID at the ARC Northern Chesapeake region. I guess most importantly, how our frontline workforce was impacted and some key takeaways about what we are learning during this time, because we are continuing to learn during this time. And also, Max represents over 100 providers doing what we do. And so I've gained some perspective from them as well over during this time. So at the ARC, we are now using the tagline with our team members, Reset, Reimagine. And since the pandemic, hopefully this only comes once in our life, we wanted to, reopen and rebuild some of the supports in a way that makes sense. Many of our systems have wanted to change over those years, but those systems, are just difficult to change. But a lot of the changes that we're looking at are going to have a direct impact on our direct support professionals. That is what we call our frontline workforce. In the world of IDD, DSPs are the people that provide the direct support that enable them to live in their community. Their families rely on this workforce to provide reliable quality support so they can work and have respite for the day, today's stressors, or of the caregiving. The challenges in finding, keeping, and training this workforce has already been talked about with prior presenters. And we were in a crisis level prior to the pandemic, and now it's just been compounded. At the ARC, we support over 400 people with IDD in Hartford and Cecil County, some who live independently with roommates or in their family home. So next slide. This slide is just a slide showing you that before COVID, during the height of it, I know we're still in it, and our current status. I think it's important to say that our workforce at the ARC may be different than some other direct service workforce who primarily work with older adults or people with physical disabilities. Our coaches do that as well as navigate the community and oftentimes find employment in addition to personal care and then delegatable medical tasks. So the first half of this slide, it shows the different services and the impact that happened. So the first one, a community integrated employment, that's helping people with their jobs, find jobs, continue working in their jobs. So you'll see that we had almost 100 people who were working independently in the community. And on March 13th, that was kind of our day of reckoning at the ARC, is many of employers and as well as us, we shut down. And so, but we did have over 30 people, it was like 36 people that were considered essential employees, people who had intellectual and developmental disabilities that were still working during this time. And we're back up to about 60. So employers are back hiring and we're back providing those supports and getting them jobs. Our transportation, we transport a lot of people for employment in Hartford and Cecil County to get to their jobs. And we continued to do that for our essential employees and then transitioned during that time to find them more independent transportation. So you can see now that is something that we are no longer doing, transportation because of health and safety reasons. And then you'll see the next piece is that we had a number of people that we supported during the day, whether they were looking for jobs, navigating their community, and that was shut down almost completely during COVID. And we're back to doing some small community groups and doing virtual supports. So we started virtual supports pretty early on. And for some people that worked good. We also have a residential program. And when COVID hit us, it became a 24/7 program. And we were lucky in the sense as an organization, we had a number of day team members that were able to pivot and transition over to our residential program. And then so they supported people during the day in 24/7. And so we were able to manage and keep a lot of our workforce. Personal supports is just another program that we provide. And you can see that it was greatly impacted except for the essential supports. And that is for people who live with their families and get evenings and weekend supports. The next part where you see family support services and team member numbers. The first part, family support, that's just something that we provide as an organization to families who need social support, who need educational training, who get support groups, benefits training, basically an information and referral source. And that has grown dramatically in the last couple of months just because of the stressors that families are experiencing. And then our team members. And as David pointed out, we do not have independent contractors. All of our team members are employees. And we did help people find the childcare once our group was deemed essential and help them find childcare. And also, we did not have a lot of PPE in the beginning. We were not given much of that. So we had to go out and find that just like everybody else was finding that. Over the course of time, we've been able to get some from the administration or from our health department. So I'm going to go ahead and go on to the next slide. So how has this transformed our workforce? So to date, like I said, we were able to deploy a lot of people to residential. We've learned a lot about using virtual technology. And most importantly, we've learned that our direct support team members are essential. In fact, they were the heroes during this time. And they are the group that showed the resiliency to continue to show up to work and manage what they did at work as well as when they were away from work, because we all know that they were putting not only their lives in danger, but also potentially their families' lives in danger. And many of our direct support workforce, because of the pay, they work for many other organizations. And so we were able to connect with a lot of our program partners in the county and talk about ways that we weren't cross-contaminating during this time. The other thing we learned is that the people we support and their families are very resilient. In fact, many of them, especially during the virtual supports, learned a lot, and we learned a lot about the strengths that they have. As prior presenters have stated, we have struggled as we start to open up and start to do a little more community day activities. We don't have a lot of team members in our pipeline. We used to get over 160 applicants in a month, and that has dropped to 60 applicants, and that it's been difficult to do that. Also around training, how do we train? We're actually doing hybrid training, some in person and some virtual. We were able to do that. And next slide. So this was about how can we take what we've learned and transform, keep what has been working, but also transform. And what you see in red is the stuff that is negatively impacting. And as prior presenters have said, we've struggled for years prior to COVID around funding and how we can make this work. So these low wages, lack of reaction by funders to do something, and we're always waiting for a budget to be cut, makes managing and supporting this workforce very difficult. It's strained the workforce, which has led to significant problems maintaining the staff. And we all know that the quality of supports that someone receives comes from the person closest to them providing the support. And if this is always a new person or an undertrained person, the quality of supports is not what it could or should be. At DDA, we were approved for Appendix K, and this did allow flexibility in our service and types of support. It would be helpful to continue that after the pandemic. Our workforce was deemed essential and saved lives. And with the minimum wage increase, we're seeing more funding come through. And also we were given some funding for when people tested positive or were waiting. We made the choice as an organization to go ahead and provide enhanced pay as well as hazard pay during different times of this pandemic. I've already mentioned the difficulty with recruitment and retention, and so we did see people leave us for work, still hazardous, but like at distribution centers or grocery stores, other essential businesses, because they were still paying more than we were able to do. We've been working on diversifying our workforce over the years, such as looking at apprenticeship programs for students in high school. This needs, though, to be recognized as a field with a living wage component. A few years ago, we were going after some funding for recruitment, retention, and training, and I was told that we didn't qualify because our employees didn't make a living wage and they could not support a family on that. We need to be aware of the rules, as we've heard earlier, about immigration and their potential upside and downside. And we need to continue to invest in our current team members through recognition of pay and shout outs. During turning the organization upside down and spending our time specifically with this direct care workforce happened during the pandemic. And we've received feedback on how appreciated they felt, and many said they stayed because of this. Training, let's be honest, most of our training is about onboarding and the basic health and safety trainings that we have to do. We did implement a lot of trainings around COVID during this time, and it was all done virtually. We've learned through the course of time, blending our training modalities is actually working better. And so, bottom line is we need a well-financed long-term care system that provides quality supports, and one that can withstand any crisis and increased demand for these positions now. and in what the future has to hold for us. Next slide, I'm done.
Thank you very much for all the work that you do to support this workforce during these crazy, uncertain times. With that, we have time for a couple of questions. Is there anybody, I'd remind everybody to put any questions you might have in the chat, but I've got a broad question for each of you. And since David started, I'll go back to David. David, what role do you see for legislators, going forward? We've talked a lot about challenges, but from a transformation side going forward, what's one thing that we could be doing as we talk to legislators moving forward? And have you seen best practices in other states that might lead us to moving forward?
Yeah, I think that framing the issue not just as a frustrating series of very deep challenges that we're all confronting, but also the opportunities that we have to improve on the system. I think that framing is really important. And, not viewing it just as a money pit. I think, when you're looking at dollars and cents and you see the Medicaid budget and you see, increasing reimbursement rates will lead to such, this X number of millions of dollars in extra state expenditures on Medicaid, and we can't spend that money. It's all just throwing money into it. One of the things that we need to recognize is that that's an investment. And as Robyn was pointing out, that money gets invested into local economies and communities and back into Maryland. It's not just throwing money into a black hole. And it also in addition to improving the quality of workers' lives and improving retention at these agencies, it also improves the quality of care and helps people live, better, fuller, more independent lives, and makes the whole industry more sustainable. So I think reframing it from just we need to spend more money to this is an investment and an opportunity to improve all of the things all at once if we do it in a smart way is one way to think of it.
Well, thank you. I've just got a really quick follow on, and I know we're short on some time, but who do you think is responsible for actually doing the framing, right? We talked to your point of we need to reframe. Who's really responsible for doing that reframing of the conversation?
Yeah, I think we all are. And I think that's one of the things that we're here today for, maybe. There's no one who's going to fix this problem other than us. There is no, particular, interest group other than us. So if all of us think about that, and I don't want to eat up all the time if Robyn or Sean or Mike or someone else wants to jump in.
Well, it's always about education, training, and investment, and those three pillars, if you see them, again, if you see investment and education and training as the three pillars that we build on to build the quality of our workforce, we got 50 million baby boomers coming down the pike. We have some huge challenges, and we have to see them as investments, not a money pit. I like your analogy or your thought.
I mean, I would just say that I always point everybody to Washington State. It's got its challenges, but Washington has a living wage. They have significant standardized training, and actually training that cuts across all settings so that we don't have this thing about CNAs being trained differently than home care aides and other support professionals. There's cross training there. They have a long-term services and supports financing mechanism. They're the first state that has actually is supporting that through taxes and a few other things so that people who are not on Medicaid have access to pay. Because if we raise reimbursement rates for the Medicaid program, but what does a modest income family do when they need to hire a staff person and they don't have the resources? So there are other states that are further along than Maryland and DC. And I think that it behooves state legislators and state executive branch people to take a look at some of these other programs and understand how it works there and how it might be adapted to us in the region.
Thank you for that. I have another kind of broad question, and I'm going to direct this initially to Sean. What role do you think employers have in this transformation? And what's one thing or two things that employers, in collaboration with some of the work that you're doing, could help move this forward?
Well, first thing is make people employees. David, I think that is absolutely something that I didn't realize that was such a huge issue for our field. And I think that's the first thing they can do is treat their employees with respect and the benefits that they absolutely have a right to doing the type of work. And then second of all, I think is to collaborate. I mean, independently, I am running a training that has ladders for our employees, but there's no statewide recognition of their CEUs that they're earning from me. And we have now joined with NADSP and National Alliance of Direct Support Professionals that is making our badge system at least recognized by other groups. And I can tell you, we've had 32 people go through that, and they stayed through the pandemic. In fact, that retention group with those team members that chose that path have over 90% retention rate. And so as employers, I think if we can come together and talk and do what Robyn talked about and have these, so we're not just independently training everybody and wasting some of the resources that we have, but have it be either a state or national recognition of the quality of the training that these team members need and would be better quality care providers.
And just to briefly, if I could just jump off
what
John was saying, if that's okay. One of the things about home care is that it's sort of a paradox. It's a really numerous workforce with like 3.2 million workers across the country. So it's huge. And it's sort of everywhere and nowhere because it's not all located in one place, which means that we don't necessarily have a great idea of what's happening with that workforce. And right now, unfortunately, the state's, sending all this money through Medicaid to pay for the work, but there's no collection of data on those residential service agencies' labor practices or wage practices. So just as a first step, one good thing to do would just be it's a pretty simple thing, just require that that those RSAs report back to the state what their wage rates are and whether they're calling their workers employees or independent contractors. We have a bill that would do that. And I'm hopeful that maybe we can get it through this year. And again, it's just about making sure that it doesn't do anything about the agencies that are already doing the right thing, but just the ones that are not. And the state should want to know how its money is being spent, right? You want your state money being used to support good jobs and not to violate workers' rights in a way that also hurts consumers of home care. So that's just Sean said he wasn't aware of sort of this problem, and a lot of people aren't. I think most people aren't, even those that are engaged in this industry. And I think we need to just sort of raise the profile of that problem, and in doing so, I think we'll fix a lot of the problems just by bringing people into existing social safety net protections.
Great.
Yeah, I mean, I go back to Washington. If you take a look at what Washington has done, they've leveled the playing field across this so that the home care aides, the PCAs, the ones who were contract workers are not contract workers. And I think it's just really critical to, I mean, the one thing that I think we keep trying to punch these things in silos. And every time we do that, we create more problems. So my sense is we need to have a thorough review of the landscape of this workforce across these settings and think how we're going to rationalize it. And I think, as David said, or maybe it was Sean, we probably have a lot of money in the system that's being completely poorly used that could be redeployed. So.
Yeah, well, and as a personal note, I would observe, and I've observed this with my wife occasionally, we as a family are considered probably, I guess, middle income, but we are one disability away from, if you have a major disability and you need care, you're going to have to get on Medicaid, which means you have to get rid of all your resources and essentially tell the state that when you die, they can take your house. That's just not an acceptable way to run a railroad or a government or anything for people who want to retire and feel secure.
And I'll end with, there is one question in the chat about what's the role of the governor's workforce development play in all of this. I would let you know that, our role is as ambassadors and connectors and to bring people together in a collaborative mode, and whether that's educators, legislators, or employers, that's where we've been working really closely with the collaborative, with those folks to bring them together. So we look forward to continuing in that role. I think at this point, I'd like to thank each of our panelists for all of their wise opinions. And what I say in most of this, we all do this because it's the right thing to do. I thank everybody for all the work that they've put in, and I'm going to turn it back over to Mike.
And I'm going to thank everybody as well. This has been an excellent opportunity. This is the kind of a resource that we're going to want to get online, be able to get out to our staff and to the advocates in the field, so that we can move toward the legislative assembly, and maybe do a feature just on that issue alone soon, about what kind of legislation needs to be passed and how we move the ball forward in really collaborating to make a difference in the direct care workforce. So thank you all very much. Appreciate it. Christina, anything else that we need to say on your list?
I think we're closing with Dr. Brown. So if I think we're done, we can let her share the closing remarks.
All right. Sorry about that. I didn't see that on my list. I was looking at the wrong place.
No problem.
Go ahead, Dr. Brown.
Wonderful. I'm going to go ahead and share my screen. Christina, am I going to be able to do that? Looks like I can.
Yes, you can. Mm-hmm.
Wonderful. Okay. So, hi, everybody. I'm Dr. Charlene Brown. I'm the founder of a couple of startups that have focused on the direct service workforce. I was the founder of Caregiver Jobs Now, which was connecting caregivers to meaningful jobs. And in that work, we really served as, we created a framework where the caregiver was the center. We had meetings about caregiver centricity, and we brought that mindset to sort of everything we did in this sector and everything we're doing in this sector. And so these closing remarks are really an attempt to summarize the 3 webinars that we've already had, and just kind of talk through what we've learned, what we can do. But I want you to understand that all of that is going to be through the lens of at least attempting to place a lens of the direct service worker in these closing remarks. So thank you. We've had 3 webinars, and I think some of you have been participated in all 3. So that is fantastic. And kudos to Ron Carlson and the Rodwin Institute for making this series happen. Robyn showed us earlier that 13% of Maryland's COVID-19 deaths were in nursing homes, assisted living facilities, and group homes. So if we keep that context around the pandemic and the workforce and the fear and threat that people have. Several speakers talked about the industry challenges that existed before the pandemic and that are still true during the pandemic. And they haven't gotten better. So DSWs still feel undervalued, they're leaving the field. Wages, 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 turnover, racism, pipeline, misclassification, recruitment and retention. We've been hearing this, discussing this, having meetings about this, having conferences about this, having focus groups about this for years and years and years. So that these things still remain true. And I think that the consequences of those challenges have been felt more acutely during the pandemic. We had the chance to hear some really interesting and positive responses to the pandemic. We had DC's enhanced payments for Medicaid frontline workers, Lifespan's working on a new training program. The Caroline Center has this amazing wraparound support for CNAs that is phenomenal and deserves to be highlighted. All of the associations, Minka, Lifespan, and so on, have provided PPE support to their members and beyond. We had tutoring programs, creative transportation. We just heard the ARCs Reset and Reimagine. And everybody that has presented has talked about appreciation, efforts to visibly show appreciation to the direct service workers in their networks. And most have described some model of providing additional pay, bonus pay, or hazard pay. And we all recognize that this workforce, we knew before that they were essential, but now it's all the more clear that they're essential. So I really celebrate these positive responses. The challenge is I'm not I'm not certain that these are representative or not. So we don't actually have a true sense of the landscape. And as Robyn suggested, we really do need that to understand to what extent are employers misclassifying workers. We definitely know that wages are too low. We definitely know that, and we heard directly from direct service workers in the first webinar, we heard about agencies and employers who were not providing PPE, not just at the beginning of the pandemic, but as a principle, they expected workers to provide their own. And perhaps there's some overlap between that and this concept of direct care workers as contractors when they should be employees. We heard quite a bit from, not from the participants who are offering programs, but from the direct care workers, the direct service workers who spoke about not having sufficient pandemic training. Morale is compromised. We had one of the speakers who said she was leaving the field. We all know that the largely African and African-American care workforce in Maryland is disproportionately affected by the COVID pandemic personally, in their families and their communities. This is the result of an environment where this workforce isn't valued. And so that lack of value manifests in how they've been managed and treated during this pandemic. And again, the amazing success stories and descriptions that happen during these webinars are phenomenal. I've been deeply and truly impressed by some of them, but there are many, many others who are not having that kind of support. And it's part of how we failed direct service workers during the pandemic. So what have been the recommendations? We've had speakers who, we all want to build on this momentum. It's like, it feels redundant to say pay a living wage because it's so obvious, but now there's data to support the possibility that you could actually recover some of the additional costs of paying a living wage through better staff retention, valuing and appreciating the direct care workforce, funding career ladders, Medicaid reimbursements. Again, these are topics that have been longstanding issues in the field. But again, the pandemic has highlighted just how critical they are and how important they are for the direct care workforce in our communities. Policy changes, ending wage theft from worker misclassification, which was the discussion right before this one. And we heard from Wendy and we heard from the Caroline Center about reimagining ways that we can educate CNAs both before as they're becoming CNAs through e-learning and simulation, and after they are in the workforce, whether or not they're CNAs or home health aides or other types of direct service workers. So these are strong and powerful recommendations, and I fully support them. But it's not enough. I believe, so this is where my opinion comes out, we need to fundamentally reimagine the career framework for this workforce. I propose a DSW-centered framing of everything. So if you think of the way we think about patient-centered care, and as a physician, I'm a huge advocate for patient-centered care or resident-centered care or client-centered care. What about DSW-centered work in an industry where the overwhelming majority of the workforce are direct service workers? How are we thinking about our operations, our systems, our structures through the lens of the workforce? Find out what the direct service workers in your orbit want. Don't rely on these proxies. Actually talk to them in structured ways that are consistent. Recognize the human value beyond just meeting the pipeline needs and the high turnover in the staffing. Like each and every direct service worker is a human being that actually may not have the same socioeconomic framework and the same cultural framework, but they have such unique and powerful insights about this industry and about how can we integrate those insights in a systematic way into operational redesign through the lens of the direct service worker, who is, again, the overwhelming majority of the workforce. I believe that if we collectively, and again, most of you on this call probably already believe this, but if we collectively in this industry come to believe that we have a lot to learn from workers, if we believe that they know things we don't know, and that our operations and our systems and our delivery of care and our fairness as employers will be improved by learning from the workforce, I think that could be transformative. How do we think about the future? The pandemic has shown us that without this workforce, there's nothing. The industry can't survive. And now there's an opportunity to dig deep and learn as much as possible and create ways and systems so that the direct service worker has a voice in the shaping and operation of long-term care service delivery across the different settings. And they should be paid for that work. So do your advisory boards have direct service workers on them? Do your committees, your administrative committees, do they have direct service workers on them? Does your board of directors have a representative direct service worker on them? How do you integrate direct service workers into administrative decisions? Their views and their insights could really help, especially because the pandemic, we're not in a post-COVID environment. The pandemic is still ongoing. How do we reimagine supervisory structures? I think someone talked about the importance of the supervisor in retention. Well, there's some pilot efforts in the Midwest to organize CNAs into their own departments. And there are roles, there's like literally director of CNAs, where you actually take extremely experienced CNAs and you put them in charge of a department of CNAs. And then that director of CNAs reports to the chief nursing officer. How do you integrate CNAs into your executive decision-making all the way up to the top? How do you avoid proxies for direct service worker voices? Include them, pay them for the voice, assume. So yeah, that's my sort of, my integration of what we've learned from the myriad presentations over the course of these 3 webinars, which have been phenomenal. And I think we can take things a bit further. And so that's the framing I'd like to offer. Now, there are a couple of things that didn't come up very frequently in the presentations, whereas like low wages and turnover came up over and over and over again. I think the concepts of structural racism and workplace discrimination only came up once or twice. But I encourage you to consider that all of our work settings are probably rife with challenges that have been invisible, especially in Maryland and DC, where the overwhelming, PHI did the study a couple of years ago that showed that the overwhelming majority of the DSW workforce is African-American. So how are we thinking about those voices, and how are we making sure that we're creating safe, encouraging, and equitable workplaces? Finally, and this is completely self-serving, Wendy. So Wendy just gave a huge talk about all of the strategies for integrating simulation into education. Well, yeah, I'm a huge proponent of that. So personally, if you can see in the bottom right hand of the screen, the name of my company is CNA Simulations VR. So I actually am a huge proponent of the power of simulation in transforming and enabling enhanced education during this pandemic. And those are the types of innovations that I'd like to see continue post-pandemic. That will really be up to the boards of nursing. But let's take the time to demonstrate the power of the current virtual learning methods so that we can continue to grow our impact on the pipeline for this workforce. With that, I'm just gonna thank all of the MCs, the speakers, the moderators, the audience participants, especially those of you that hung in there for all 3 webinars. Special thanks to Ron Carlson for having the vision to create this webinar series, and to the Rodham Institute for hosting it. My name is Dr. Charlene Brown. I love talking to people, so if any of you want to get in touch, my email address is on the screen. And with that, I'm going to hand it back over to Mike, and thank you for the opportunity to close.
Well, and thank you very much for an excellent summary and for issuing some challenges to all of us about how we think about this work. I want to thank the collaborative itself for existing and for making a difference. It has been an excellent endeavor and continues to have excellent programs like this that will reshape and reframe the outcomes for future folks with disabilities and the workforce that serves them. With that, I want to thank everyone for attending, and we will let you know when this is available so that those of you who wish to use it can, and we'll be able to use it with your staff and with other advocates in the field. Thank you all.